you so
Myself, Sankalp Sane, Marketing Manager from Innovcare Life Sciences. Welcome all to this interactive show, the Pundit @Ritu show, supported by Innovcare Life Sciences. Today, we have a very special guest on our show, the teacher of the teachers, Dr. Sunita Tandulwadkar. Welcome, ma'am.
very warm welcome, dear ma'am. Very warm welcome.
It is important for us to understand what makes Pundit show unique and special. It is knowledge sharing platform for experts as well as young doctors. The perfect mixing and mingling done by Ritu when it comes to strike balance between basic questions and advanced questions. Not only from India, but doctors from across the globe are getting benefited from the show. It has covered all the aspects, be it gynecology, obstetrics, sexual wellness, women's health, medical legal aspect, and others. With this, I would request Ritu Madam to introduce our special guest, the teacher of the teachers, Dr. Sunita Tandulwadkar Madam. Over to you, Ritu Madam.
Yeah. Thank you, Sankal, for the introduction. Thank you. Friends, as all of you know, I believe on the concept that knowledge is a superpower. With this motto, I will keep inviting the guests, a very knowledgeable guest from our fraternity who believe in the knowledge sharing. With And every week I am inviting two of the stalwarts from our fraternity who are very diverse in the knowledge and very believe in the sharing of the knowledge. I am here, your host, Dr. Ritu Santwani from Pune, director of Shambhal Women Clinic, Pune Test Tube Baby Center. Today's our guest is very dynamic, very energetic. Ma'am doesn't need any introduction. Ma'am, we can say, ma'am is from my own city, Pune, the Punya Nagri. Ma'am is known as Dakhanchi Rani, the Queen of Deccan. A very, very warm welcome to you, ma'am. Ma'am, from my side, these lovely roses for you.
So sweet. They are as beautiful as you.
Thank you. So, friends, thank you so much, ma'am. Yeah. Sankalp, can I have the biography of ma'am, please? Sankalp?
Yeah.
Yeah. Yeah, please make it full screen.
Yeah. Can you see? Can it be seen, ma'am?
Make it little. Yeah, it's okay. Yeah, it's okay. Yeah. Dr. Sunita, ma'am. Ma'am is HOD OBGYN Ruby Hall Clinic, Pune, Chief IVF and Endoscopy Center, Ruby Hall Clinic, Pune, Advisor and Consultant, Dr. D.Y. Patil IVF and Endoscopy Center, Pune, Founder and Medical Director, Solo Clinic IVF, a Center for Excellence in Infertility, Pune, Founder and Medical Director, Solo Stem Cells, a Stem Cell Research and Application Center, Pune. I can say very proudly, ma'am was the first to start of this stem cell in the whole, this Maharashtra region. Founder of Solo Research Foundation, sponsor a birth initiative, Pune. Next slide, please. Yeah. Ma'am has so many organizational posts held. Ma'am is currently the IH president. Ma'am is the chairperson of Maharashtra chapter of ISAR, founder honorary secretary. Ma'am is second vice president for the ISAR. Ma'am is vice president of the West Zone of our FICS 2015 to 17, International Society of Gynaec Endoscopy, elected board member 2013 to 17, Journal of Human Reproductive Sciences, reviewer and advisor. Ma'am has so many academic achievements with her. Ma'am is authored and 6 books and 23 publications, contributed many chapters to national and international books, delivered 58 keynotes and 17 orations, in addition to being and invited faculty to 23 international conferences. Yeah, next, please. Yeah. Ma'am has so many awards with her. The Pride of Foxy Award 2020, Bharat Gaurav Puraskar 2019, ISAR Best Personality of the Year 2018 to 19, Best Medical Practice 2016, Europe Medical Association, Best Citizen of India Award 2016, Glory of India Award 2016, Best Gynecologist of Maharashtra 2016, Ahilyabai Holkar Award 2015 for her work in the field of the women and child health, Most Emerging Gynecologist of Maharashtra 2015, Rashtriya Gaurav Award 2015, Letter of Appreciation 2012 from the President of India, Sarvashri Award 2012, in the recognition of her outstanding achievement in the field of IVF and endoscopy for 20 years. Besides this, also there are a lot of achievements and madam are having. So it's our proud privilege that teacher of teachers, Madam Dr. Sunita, please stop sharing. Yeah, that Madam has accepted my invitation. So Madam is here today, enlightened to all of us. So before we start the show, ma'am, this is the query in each and every when we all are getting inspired by seeing you कि हमको कुछ तो करना है मैम की तरह. So ma'am, my conversation will be little Hindi and English I am keeping because some doctors yesterday told me, drop me a message कि कुछ कुछ तो हिंदी में भी बोलो, पूरा English बोलते हो आप लोग. So ma'am, my first, please ma'am, what is the secret sauce of your success?
Oh my God. Ritu, this is such a difficult question to answer and a little awkward because what's the definition of success? If you say the success because I got my Guru Gagangiri Maharaj, then yes, I'm successful. His blessings, I could help my hands. He has given me a skill. Then maybe I'm successful because with my endoscopic surgeries, I can relieve pain of so many in such a minimal invasive way. If you think the success is giving babies to thousands of couple, Yes, again, God has helped me to do so. If you think success is getting a wonderful family, your parents you don't choose, your child you don't choose, but your husband you choose. And again, if you say so, I'm very, very lucky to get the best of the husband in the world. If you think success is because I have a beautiful family, friends like you, whom I don't have a word NO, then yes, I'm blessed with hundreds and thousands of friends from our FOXY organization, from IAG organization, from ISAR organization. And any organization, any relationship you want to cherish, then it is always give more and expect less.
Wow, ma'am. Thank you. Thank you so much, ma'am. What a beautiful answer you had given. Ma'am, in fact, the all who are coming in vicinity of you, I can say they are lucky to have you. Ma'am, my very next question to you, ma'am, please give us some tips for the young budding gynecologist. We all are getting motivated by seeing you. Ma'am is so hardworking. Still, I know the ma'am schedule is very hectic. Ma'am is hardly sleeping for 3 to 4 hours in a day. So, ma'am, please give us some tips for the young budding gynecologist before we go on to the presentation.
Ritu, most importantly, 2 years ago, Dr. Manish Machwe had one conference on medical legal. He
Yeah.
called me, you just participate in this, give me keynote. I said, I'm not the expert on medical legal. Fortunately, I never had any legal complications. So I'm not the best person to. So he said, no, I want then, give me a mantra of medical legal free practice. So there is no mantra. I want to tell all the youngsters today, the youngsters wants to reach to the top on within 5 years of their practice. You have to climb up the staircase, and if your staircase is long, one step at a time. Your experience will make you expert. Don't have shortcuts. There are no shortcuts.
Sure.
We are in a medical field. Our smallest mistake is a great disaster for a patient. We can't say even after 25, 27 years now. I have started in 1992. So I don't even know how to count. So these 28 years of practice till today, I go in the operation theater as if it is my first case because it is the first surgery for that patient. I can't be overconfident. I need to be confident, but don't be overconfident. So today's youngsters, I want to say, when you climb up, always remember you reach to the top of a hill, there is always a downfall after that. But when you reach the top of a hill, you see many more hills from there to climb up. So you never, never reach to the top any day in your life. It is always slow and steady. We should remain the student. Even in the webinars, in the conferences, I learn from youngsters. So don't become a teacher. Remain a student. Everything teaches you in life. Every patient, every surgery. No two patients are same. No two surgeries are same. So you should always have your habit of learning from the case, doing excellent for that day. Your patient has come with lot of hopes. I always think myself in their chair. What I expect from my doctor if I would have suffered, and then I will do what I would have expected them. Treat them like a family. Always think your patient as your sister, your daughter, your grandmother, your mother, depending upon what age she is. And what you would have done for her, you will die for your mother. Same, you die for someone else's mother. So, passion, hard work, dedication is the success. Discipline observed every day is a success.
Yeah. Thank you. Thank you so much, ma'am. Ma'am, one more question. What motivated you to become a doctor?
Ritu, frankly speaking, 78, 79, where my 11th and 12th standard, 10th standard, 79, I passed out. I had a huge gang of friends, and we all were thinking, oh, now we will all go to commerce, we'll have a great life of a college. I just wanted to have a gala time. I'm from my Marwadi background, seeing my kakis, my bhabis, my everyone enjoying the life. You know how Marwadi families, all festivals. And in 10th standard, I stood first in my board exam. And all the three principals, there were three important colleges, and all the principals on Sunday evening were at home asking my father to have an admission to their college. So when enter home happily, having nice time with my friends, I saw them. They said, "You are joining." I said, "No, my all friends are going in commerce. We all are want to." So my father sat and he said, "You had a great time. You stood first. You are a fantastic career. And it's a time to take life more seriously. So I want you to select science." And that's how I entered in science. Now, in our year, there were only two options, engineer or medical. And that's how I entered. But once you enter, you sit in that anatomy hall with the dissection and you get that passion. So tomorrow you are going to have a patience. Today you are working on a dead body, but tomorrow you are going to have a patience and you are going to move your fingers and you are going to do best for them. So I need to be best in my anatomy, in my physiology, and that's how you just develop. I think, sometimes I'm lucky to get a best of the guru in my life, Sri Gagangiri Maharaj. And he always have carved your path. I have to blindly walk on that path. So sometimes you have those Guru Santa, they do for you. And they have given us a life of givers. Every life we may not be giver, we may be taker, we may be receiver. In past life, I might have received a lot from my patient, and it's my duty to give them back in my this life. So God has given us more than we have asked for. A life where we can make many more families happy, many more individuals happy. So work hard here and do it. Life is short, unpredictable. So every day, try to do as much as you can. It's your karma you are taking back. Rest is going be here. हम खाली हाथ आए हैं, खाली हाथ जाएंगे.
Awesome, ma'am. Awesome. मैम आप कितना अच्छा बोलते हैं हर चीज के लिए. यू आर मैम एक्सपर्ट. Heads off to you. Heads off to you, ma'am.
This is what my belief is, beta.
Yeah. Ma'am, now we can start your presentation.
I will just share the screen.
Yes, ma'am.
That also I want to tell my youngsters one important thing today is every day before starting the operation, frankly speaking, when I'm taking a wash, I present the case to my God. I tell the complete history and what is my plan, and I request for a blessing. Then when we are all washed up, my sister, my patient is pen drip ready. Before I take a scalpel in hand, we 60 seconds in the operation theater is a pin drop silence and prayers. We have a lot of Malayali people, Keralites. We just have to do one thing. Whichever God you believe in, just pray to that God that today will be the best day of surgery in my life. And believe me, everything happens like a miracle because we get those power and that power works and we get the name Ritu, frankly speaking. I'm a very small part. So today we are going to talk about, first of all, thank you, Ritu. Thank you for giving me an opportunity. I know in the evening I excused you. I said, can we postpone today? Invited in for webinars, and they were all who were contesting being a president. I felt it is very unfair if I say no to them. They will feel bad, and that's why I just requested. But when you say no, it is pre-planned.
Yeah, ma'am.
Ritu, I felt you gave me an opportunity to communicate, to connect, to many more. Even if one person is hearing and they get motivated, they change their attitude, they get God in their practice. My lecture is achieved, our evening is done. So thank you, Ritu, for this wonderful time for me. Now,
Thank you, ma'am.
Endoscopy Mastering the Challenges was my theme of this year. We all need to master the challenges. What you have learned 3 decades ago doesn't stand anymore. We have to keep on doing every day. 1 minute. I'll just move this bar out. Okay.
Okay.
So today I will be talking about mastering the challenges in endoscopy. Friends, we all know that we are a keyhole surgeon, endoscopic surgeon. It is best for the patient. But as an endoscopic surgeon, we often face many challenges. Uh, and we need to master them from time to time. These challenges can be because of advances in technologies. When we were doing our post graduation in 86 to 89, we never had the telescope camera. We used to see from the telescope one by one in rotation. When you were very young, your number used to come last, and your teacher used to say, okay, now move on next time. So, and then we started with single chip camera of Lemke. And today the technology has advanced that we don't have only 3 chip, we don't have only HD, we have a 3D systems, we have a robotic system, we have a fantastic energy sources. You will watch them as we go. But we need to master them. It doesn't come. I do robotic surgery, but I needed to go and take a special training of it for 2 years ago. Again, the masters, with the patients, you need to face the challenges because no two patients are same. There may be obesity, huge obesity. You need to be very careful. So I tell my students, don't limit your challenges, challenge your limits, challenge your thoughts. Each day you must strive for constant and never-ending improvement. Now, endoscopy has given us a chance to be creative in many ways. Let's take a fibroid. We all know the fibroid, that is a tumor of the uterus. Usually we call it as a benign tumor, and every surgeon differ in the way they will perform this surgery, whether from a selection of a cases to the entire procedure. What is important for every surgeon, whatever your technology you have mastered in, prepare yourself well before each surgery to excel your intraoperative performance. This is what I call mapping of the pathology. So these rounds are all the fibroids. Because Ritu, you have a Facebook and the YouTube, I thought let me talk little bit even the lay terms also.
Yes,
So
yes, ma'am.
maybe all more tumors. You know, patient comes and says, yes, I have sonography done, I have MRI done, but they don't understand. They have not done anything into so much of a detailing. It's not the MRI. It is the person who reads the MRI is more important. We all know, Ritu, we are fortunate. In Pune, we have Dr. Manoj Chinchwadkar, a fantastic sonologist. Last 2.5 decades, he does the sonography and he give me this. So even if the patient has to retain the uterus, I have to remove these so many, I know how I will be planning. So it helps me to do the best of the planning. In laparoscopy, your team is your patient herself. It's very important that with this mapping, you sit with the patient, explain them what are these fibroids, how I'm going to operate, which fibroids I'm going to take out, which I don't need to be, or whether she needs a removal of the uterus if she is no longer wants a baby. Your assistants, everyone, should know the entire surgery. Your anesthetists, they should know how long you are going to perform, how much head low you need. If she is obese, how we can compromise and with the best interest in the patient, not to give too much head low, not to give too much intra-abdominal pressure. Your sisters and ward boys, believe me, my ward boy is my best person in the OT for last 20 years. He knows exactly when the trocar goes in, my telescope goes in, give a head low. The moment when to give an intra-abdominal pressure, increase, decrease, everything. So they optimize your surgical performance, and the entire surgical team. Dr. Manisha Karmarkar, 20 years, Dr. Raju and he, my anesthetist, a fantastic team we have. Now, of course, she remains so busy with so many other responsibility that we are working less together. Now, this fibroid, you imagine this fibroid, if I don't remove it well, I believe in doing intracapsular. It means we don't damage the cavity. We remain outside the cavity, remove the capsule, and then take out these myomas. If while opening the myomas, you open the cavity, this patient has to become pregnant later. You just see laparoscopy, I'm not touching the bowel. It's absolutely immediate physiological return and mobilization of the patient. So there is no doubt that laparoscopy is the best, but what is equally important is you have to perform best. I usually take out one myoma and then I remove the other, and only after suturing the first one, because the vasopressin which we put in acts only for 20 minutes. So if you want to make it bloodless, look at this. A different myoma. They are medium size. They are deep rooted. They are compressing the cavity. This lady can never conceive unless I remove them. But at the same time, I need to remember that she wants to carry in this beautiful uterus the pregnancy ahead, and she don't want to have a rupture during the pregnancy. So closure of the myoma, not to allow the dead space, not to allow the hematoma. Don't do cautery too much. Cautery will cause necrosis of the tissue, infection, and the weakening of the scar. Many a times you don't even see where the bulge is, but it is your sonologist who has told you precisely where it is. In laparoscopy, there is no tactile sensation. And if there are no bulges, see how deep I am going in, but exactly you know the site where I am taking out this fibroid. So this is all plays a very important role. Sometimes the fibroid may be very big. This is a cavity and associated endometriosis you need to rule out, and then you need to do laparoscopically. I always tell, if the patient is large, the myomas are large, difficulty to us. It is not to the patient. Recovery of the patient should be same if I'm removing 4 centimeter myoma or I'm removing a 20 centimeter myoma. Only maybe operation time may be extended 1 hour. So anesthesia time. So maybe you keep her empty stomach or kneel by mouth for 3 to 4 hours more. In laparoscopy, there is always magnification. Don't keep on cauterizing. Traction and counter traction will help. Various energy sources. Look at this. I did not open the endometrial cavity. It is the capsule. What is important is don't cauterize. Some bleeder is seen. There may be 10-20 cc blood loss. Don't bother. That blood loss I can afford. She can regain that within 8 days. But I cannot afford to do cauterization, necrosis, and permanent damage to the uterus. The end result should be as beautiful as this. Sometimes the fibroid may not be in the way to the uterus. Uterus is way away. Here it is the uterus. It is a broad ligament fibroid. This patient, before the embryo transfer, came to me with acute abdomen. And I was so worried that I'm doing her embryo transfer. Why she should be? But during the stimulation, your fibroid increases in size because of the supraphysiological estradiol level, and it has caused ureteric compression, and that's why she had a pain. So we did her ureteric stenting, and once in 2 weeks, when she settled down from that, I did this myomectomy so that her pregnancy becomes uneventful. I never wanted a stent. Now, these broad ligament myomas, they are very simple. Don't complicate the simple case. You don't need to do the uterine at its origin for each and every case. It is just you remain in the capsule, such a large myoma. Blood loss is what will be there in this tumor. Otherwise, usually the patient cannot have much blood loss if you are in a good plane.
Ma'am, sorry to interrupt you. Ma'am, slides are not moving.
What are you saying? Yeah?
Yeah, because the doctors have, yeah.
My range is very good, yeah? Are you able to watch?
I am able to watch now only the first slide of the topic.
Now you can't see my slides?
No.
Are you sure?
Yes, ma'am.
But it is showing here the screen is working. Now can you see the slide?
The first slide is only visible. Endoscopy mastering challenges.
Ah, okay. I'll stop the share. Are you sure?
Yes, ma'am. Vaibhav, can you help, please?
Yeah, ma'am.
Yeah.
I
Reshare
don't.
your screen once again.
I need to help myself.
Yes, yes. Be thankful for each challenges.
Yes, ma'am. Ma'am, now
Yes,
it is visible.
it's now visible.
I'm not able to see any of my lecture slides better.
No. Now it's okay, ma'am. Now it's okay.
It is going
Yeah.
on.
Yes, ma'am. It's going on. Yes, ma'am.
Ah, so mastering the challenges were what I was talking. You saw this slide? Okay.
3 slides we have seen. Yeah.
You were able to hear, right?
Yes, ma'am.
So I won't repeat these slides again.
No.
So this is what I was trying to tell you.
Yeah.
Endoscopy gives us the chance to be creative. So myoma, for example, I think you all heard this. The surgeons,
Yes.
every surgeon differ in their surgical skills, their technology, they master themselves. What is important is preparing yourself before a surgery. That's what I was saying, Ritu, in Pune. We
Yes,
are
ma'am.
fortunate to have a Dr. Manoj Chinchwadkar, and I'm
Hmm.
very thankful to you because he gives appointment to my patient on request whenever I want it. Because without his sonography, I don't put the camera inside. I don't like surprises in a camera. He tells me, you take one incision here, and you will be able to take out all these fibroids. So in a laparoscopy, everyone, patient, assistant, anesthetist, everyone is the team. And these are my team members. This surgery you were not able to watch, Ritu?
Yeah. Now we are able to see, ma'am.
Okay, so
Yeah.
if you see these fibroids, I'm sorry, if you see these fibroids, they are compressing the cavity, infertility patient. So you need to be intracapsular, don't open the cavity. Otherwise you will have an intrauterine adhesion. So you will get rid of fibroids, but post-operatively, she will have so much adhesions inside that you will not be still able to give her a successful pregnancy. So all ART consultant has to be best of endoscopist, or they should have a best endoscopist in their team. They all work. ART consultant, if wants to have a carry-on baby rate, they need to have an endoscopic surgeon, they need to have a high-risk obstetrician, they need to have a fetal medicine consultant, they have to have a radiologist, the sonologist, everyone, and then the neonatologist as a team member. I think you were hearing my commentary, right? So this is how I'm removing fibroids over fibroids. Usually when one fibroid I remove, I suture that immediately because we use the vasopressin and the action of it is 20 minutes. Now this sonologist has told me exactly, precisely, where are these myomas? So I know that I will be just taking an incision on that myoma, and this is another 5 centimeter myoma which is out. Just park them in a iliac fossa and keep on doing the surgery. Now in laparoscopy, you don't have a tactile sensation. You can't put your hand in. So preoperatively, your sonologist telling you everything is the most important. He tells you precisely in that uterus where to take a cut. I always tell my patient, even if there is a gold brick in this wall, I just can't dig the entire wall. I should know precise location of that. Sometimes the fibroid may be huge. This is a cavity. I don't want to disturb that cavity. We all know that fibroids are associated with endometriosis. Very important that once you go in, you confirm your finding. Now, these are the various energy sources I'm using. My sonologist had said it's a highly vascular, so I'm going to use the vessel sealing. And then you have this myoma screw traction and a counter traction, which is a basic principle of each and every surgery. So if it is such a large myoma, you use a 10 mm and give a traction. All those venous oozing will stop on its own. Don't keep on cauterizing too much. And look at this, cavity is not open. What is important is obliteration. This is a myoma capsule. So obliteration of the space is the most important thing so that you will not have a hematoma formation. There is an active little bleeder. Allow this, doesn't matter. When we do the cesarean, when the baby comes out, when we do the normal delivery, when we give a episiotomy, there will be a bleeder. So we don't keep on cauterizing them. Instead, we suture. Same principle applies here also. Now, this patient had a large fibroid and she was for an embryo transfer. You can see her uterus is absolutely normal, but this was a broad ligament myoma. Because of her stimulation, her size of the uterus has increased because of a high estrogen, and she came with acute abdomen. And we found that she had a ureteric compression because of this. So we did the stenting, and after 10 days of a stenting, we posted her for the myoma surgery before the embryo transfer so that her pregnancy goes uneventfully. So here I am trying to say, don't complicate. This is a very simple case. It looks like a 15 centimeter myoma, but it always will have a beautiful place, and you have to just छोटे बच्चे की जैसे चड्डी उतारते हैं ना वैसा निकालना पड़ता है, and it comes out beautifully. But remember, there are major vessels around there, so be very careful. Ritu, can you see? Is the video
Yes,
moving?
yes, ma'am. Yes, ma'am. Moving. Yes.
Thank you. So
Beautiful
once
present.
myoma is out, you can see this major vessel, the ureter going in. Keep them safe. This is a stent, and that's why it is seen so beautifully. So be thankful for each new challenge because it will build your strength and the character. Now, sometimes the fibroids are so many, they are deep inside. There are so many previous surgery giving adhesion. These are the bowel. Now, one disadvantage of a bowel preparation is the small intestines, they become like a flat, thin field of peritoneum. So don't mistake them for a peritoneum. The best energy source is no energy source. Use your scissors. Look at this. This is a small bowel. So remain on the uterus. One small nick here and there, and you will open up the bowel. Nothing, you can suture it, but there is a morbidity. Very rarely you can land up in fistulas. Patient needs to remain 3 to 4 days just in the hospital extra. So these fibroids, I can't even see the entire bowel is covering it. But it's equally important that you take out all these bowel, park them safely. Then next comes is the ureter. So I'm just dissecting and making this. Now, unless I remove these, all these tumors which are inside, and my sonologist has said they are in the posterior wall, I need to make. Now, she also had associated hydrosulfing. Whenever there is a fluid in the tube that is a hydrosulfings, you can see that this is a bulge of a hydrosulfings which is coming from medially. I need to see where the ureter is. I see the ureter absolutely laterally. I don't have to worry, and I can safely remove the fallopian tube. Usually I believe in excising it. And now are these fibroids visible? So you need to do extensive adhesiolysis. Keep your bowel, ureter all out. Now my sonologist said there is one more in a right lateral wall, and that is completely compressing the cavity. Unless I remove this big fibroid, I cannot give a success to her. So friends, your preoperative diagnosis, preoperative location, number, sizes, all this helps in your intraoperative performance. Sometimes the patient says, I'm not going to do. I request them, if you don't want to do it, then don't come to me for a surgery. You are free to go to anyone. I don't like to do the complications to my patient. I will never operate. I need to be very clear what I'm going to handle. I don't mind she going to someone else, but I need to have a very good sonologist. Surprises in the camera is not allowed. Removal of the uterus. Uterine manipulator, we started in the era of 1995, 94, when there were no manipulators. So I designed this manipulator. These can move the uterus up to 20, 24 weeks. I'll show you the video. And these rings, you need so many, depending upon what size. I do have many mentally retarded girls at the age of 14, 15, mother coming because they can't maintain the hygiene. And you need to have such a small cannula to make their life comfortable. So hysterectomy is another challenge. But I know that in the city of Pune, when 94-95, I did the first laparoscopic hysterectomy, I did receive a criticism. Always remember that whenever you do something for the first time, you will have both the school of thoughts coming in. Few will criticize, few will appreciate. Whose appreciation you need is your patient. Your patient in the evening, she's walking to the toilet, she's passing urine, she's sitting with the family, she's having her dinner. What else you want? I don't like to put any myoma screw. I believe in doing bloodless surgery. And you can see that the uterus is completely moved. I got an apparent lengthening of the uterine. I'm not going to do in this case uterine at its origin. So because you know complicated technologies doesn't mean you should use that for each and every case. What is important is if anytime you need it, we all know that lateral pelvic wall full of all important vessels, nerves, and the ureter. So you need to be careful. All they go vertically. So just have two blind things and just move your hand vertically and you will have the ureter on the left side and the iliac vessel on right side and the crossing structure is the uterine. Now just don't say this is uterine. Trace it down completely and this is internal iliac and here it is crossing the ureter. Sometimes superior vesicle, we all know there can be anatomical variation. So you have to be very clear with the course and because it is crossing the ureter, it is nothing else than the uterine. So another case, now this is a large myoma. This patient had a multiple myoma up to the zipisternum. So how large is how big is big? It is everyone's individual definition. In early part of your learning curve, take the simple cases. As your experience and confidence increases, start moving with the complicated cases. As the time move on, your exclusion criteria goes down and you take more and more complicated cases. Frankly speaking, Ritu, no more simple cases come to me. In India, we do have excellent endoscopic surgeon across from a smaller city to bigger cities. So you get only either because medically they are complicated, morbidly obese, diabetes, a cardiac problem because you work in an institute, or because others have refused because of a challenging case. And these are the cases you need to have a patience. You will see the entire surgery, not a single drop of blood you can see. I don't like bloody surgeries. Post-operative recovery of the patient is so fantastic. Now, I tell the girls, because we did such a big uterus, doesn't mean the patient has to be empty stomach or remain in bed for 2 days. Her recovery is 4 hours of anesthesia time and she can start the liquids. If no vomiting, I give them in the evening sandwich or apple, and in the night they can have a soft diet of dal, chawal, khichdi. I never like to keep a catheter post-operatively. We remove it, but I do keep it intraoperatively. So my anesthetists don't have to worry whether they are giving excessive fluid, less fluid. They are comfortable. You can't keep so many restrictions on your team members. But in a recovery room, we remove the catheter. So by the time she reaches to the room, she walks to the toilet. That is the most important thing. Now, sometimes, now she is a dancer. She's a very sweet patient. Of course, I can't disclose the name. And she, being a dancer, she wanted only laparoscopically. These tumors, they don't give you vertically how with the previous patient, but horizontally, they occupy the entire pelvis. I feel these are more challenging cases than the large but the vertical having the lateral space for the ligaments and for the structures to handle. But being a dancer, you need to take care and you need to be very sure that her scars are not seen afterwards. So, friends, we don't grow when the things are easy. We grow when we face the challenges. Now, sometimes you have very challenging case. This is where the pre-operative, sonologist tells you there are a lot of bowel adhesions to the anterior abdominal wall. And because she had undergone previous open surgery for endometriosis, myomas. She had a previous cesarean. I was knowing I'm expecting. The anatomical landmarks help us. But this is again only the right side of the upper abdomen, where these are the loops of bowel. I'm just cutting them. What is important is millimeter by millimeter dissection. Don't go too much in the anterior abdominal wall. You'll end up in extraperitonealization of the gas. You'll end up exposing the posterior rectus sheath and everything if you go above the umbilicus. So what I'm doing is small nicks. My assistant hand is not there. A simple grasper and a simple scissor. Small cut. Now, this bowel preparation has been done. Can you see? I compress them and the all bowel become like a thin fold of a peritoneum. But you will always have your beautiful planes remain in that plane. And then you don't need an energy source. It just capillary oozing. It will stop before your surgery ends. Now, once you finish all that, then only your assistant with the right lumbar fold comes in and down you can't even see the uterus. Your patient also knows that she has undergone, by the time she has a huge knowledge about endometriosis, fibroids, because before becoming a pregnant, she has handled all that. Now, what is important is go from the identifiable tissue. Always left iliac fossa or left lumbar region is the region where you start from the descending colon and you keep on separating. You see, if there are many loops of bowel adherent, I don't like energy sources because you never know, the other loop may be just beneath. But most importantly, you should be by-handed surgeon. How in open surgery, we use our both the hands. Similarly, in laparoscopy, you should use your both the hands. Left hand also should be helping you for a retraction. Look at this. The left hand helps you for further dissection. And if you have an excellent surgeon, you become four-handed surgeon. You have an excellent vaginal person who manages the uterine manipulation. You become a five-handed surgeon. So these are the loops, but I can see some amount of the uterus. She had a fluid collection. I love when there is a fluid collection. If you see left side, the bubble, it means there's a beautiful plane somewhere and my life will be much simpler once I take out all those fundal adhesion. Now here, these are all the bowel loops, one beneath the other, one beneath the other. You just, how the tailor takes the scissor one edge and cut it similarly. And this fluid collection has come. So you are happy, you are entering into the good plane there. Now, once your left part of the posterior is over, next important thing is taking the uterine at its origin. This is important because in case if uterine bleeds, I will land up in a huge bleeding and maybe a open surgery. So I would go and just clip the uterine so that my further surgery is bloodless. My right side is remaining, colon is remaining, pouch of Douglas I have to do. I will never jump for the hysterectomy. My next step will be making the bladder out. She had a previous two cesarean. Always adhesions will be only at the isthmic level. Once you release it, you will have a beautiful normal plane down. And I'm just pushing that. Now, once the bladder is out, left-sided ureter is out, left part of the colon is out, you go for the right side, and similarly, you perform on a right side, and you can have your surgery done. But what is important is extensively keeping your most important organs out. I think I have already showed. Sometimes I think I'll skip those videos of frozen pelvis. Ritu, we in India face so many patients of tuberculosis having a hydrosulfings, and unless I remove, this patient is one of my fellows, Bhabi, and I needed to remove her hydrosulfings before I give her surgery. She flew down from a UP and because of her hydrosulfings, her IVF had failed. So it was important for me very gently first find out where is the uterus. These are all loops of bowel around each other. Once you identify, then you can use an energy source. I'm just pushing the same because more or less same. This is the small bowel. Don't cut it. You cut it, you have cut the bowel. So you have to dissect that, and this is a hydrosulfins. This is the uterus. I like to go to the base of hydrosulfins, the origin. of the fallopian tube and then excise completely so that she cannot have an ectopic pregnancy. I skipped this video, more or less the same. Now, robotic. We have in Ruby Hall as well as D.Y. Patil Medical College, the robotics. Robotic is a fun. That means, see, I think in COVID era, what is most important is you are away. Robotic surgery might have given us the benefit. When you see initially so many movements of the hands about, you feel scared. But when challenges are what makes life interesting and overcoming them makes it meaningful. Believe me, laparoscopic surgery is more difficult to learn than the robotic surgery. Robotic is as good as open surgery. You just need to master your eye-hand coordination. The control is yours. But I don't think I believe in too much of robotic surgery for a benign simple cases of hysterectomy, myomectomy. But if it is for a hydrosalpinx, I will, if it is for a tubotubal anastomosis, I would love to have microsurgery with robotic. This patient already have one, and now her child may be 2 years old. She had a sterilization done after the first marriage, many divorces. So I don't like nowadays with the cesarean sterilization, not because they are undergoing divorces, but why to do it? There are good contraceptives available. The robotic helps, the microsurgery, the magnification. Your hands move 560 degree. So it's much, much simpler than the laparoscopy. Believe me, those who can master the robotic and join the institutes, they will realize that robotic is much simpler than doing 3D laparoscopy because, or a 2D laparoscopy, because there is no depth of perception and you are watching the TV and you are operating down. While here you are watching down and you are operating down. So it is much, much simpler to do the robotic. We thought this was my first robotic. We thought we will do only one side because I may take 2 hours, 3 hours. We finished in half hour. So I told my anesthetist, I'm going to do both the sides. And I don't know from which side she conceived, but she has already. Apart from laparoscopy, we do face the challenges in hysteroscopy. I love hysteroscopy. You just imagine the patient has a uterus and there is some tumor inside, some septum inside, and you just cut and make it normal. Such a noble way. You remember in our residency, we used to cut open the uterus completely. Now, such a large myoma inside. Patient comes in the morning with this myoma. This was a 10 centimeter. I was not sure whether hysteroscopic or laparoscopic. So I passed just the office hysteroscope to confirm, and this was the base of the myoma. It was a type O. You tell the patient you may do it in 2 sittings, but fortunately, the girl was from outside India, and we could do it in 1 sitting. Of course, they had a visa of 3 months because it is very important you ask them. There will be open channels. You just don't close the loop. Withdraw your hand. Withdraw your hand. It's just, see. Second thing is don't stop to remove those pieces. It causes bloody field. Automatically with your hydro pressure, they will move out. So you have to just keep on doing the surgery. It was a big myoma. I did examine after going in. So what is important here is your speed of a surgery. And look at this, half the uterus, we all can see such a long pieces you remove, and you can finish off the entire surgery in one go. So that is what is most important. So performing hysteroscopy is like painting on a canvas. I always feel this patient, again, she's from Pune. She was one of the anesthetist's daughter who had a repeated failure of ART. If she will be watching this, she will understand. It is her video I'm showing. I had taken her permission also. Of course, the name has to be closed. So this Versa point, this is very old, 2006 to 2010. Versa point was one of my favorite energy source in hysteroscopy because we used to use office hysteroscopy of 2 mm and you can operate through it. So this patient had an adenomyoma protruding, and if you cut in the center, it will get retracted. So your aim is to resolve, to take that out. So I'm just making like a painting, anterior wall, posterior wall, beyond which I will not go, lateral wall, beyond which I will not go, so she will not have a perforation. She has come to me for giving a baby. If I perforate, I completely screwed her obstetric career. So very, very important. The only disadvantage of this energy source is it dissolves the tissue. So you don't have the tissue for a histopathology. And secondly is lot of bubble comes. But you can differentiate the normal tissue from an adenomyotic. Just evaporated. I'm deepening the cut because corneal openings are telling me there is still protrusion. You need to go and remove and dissolve lot many things. So this is what I feel. It gives you a chance to be creative. Now, we all have learned in our medical education that unicornuate uterus, you have increasing gestation. Those who are very senior, more than 30 years, they know we used to counsel our government medical college patient, don't worry, beta, this time you had a 4th month, next time you will continue the pregnancy 5 months, and slowly, slowly you will reach 9 months. I feel how cruel we were in telling the patient that you will have definitely another 1 2 abortion before you have a pregnancy. So in 2004 to 6, I was all the time, this is what our mind becomes creative. Why she should lose a pregnancy? Only because the cavity becomes roomier? Then why not to make it roomier by taking out the complete wall? And then I sat with my, this is completely the Morris who does this job for me. And then I sit with the patient and I explain them, and then we can perform. So this is a half uterus. In a late term, it is a half uterus and you have to make near full uterus. So what is important is just cut those walls. So here I always keep a blunt scissor. For Asherman, for such patients, I always like to have a blunt scissor because I don't like to cut too much. Again, fiber dissection. Keep good intrauterine pressure. So you are always in the midway, not too anteriorly, not too posteriorly, so you don't perforate. Your one eye should be on a corneal opening, which is always in the mid cavity. So bubble helping me that it is a mid cavity, and I'm cutting and I'm cutting. I'm going to reach. So my aim is to make upper horizontal and then vertical stroke. So I'm just making the horizontal stroke, and then this is 1.5 minute video, but not edited. So it takes hardly 2 minutes in expert hand with the practice. And you can see more or less it has become like where the other corner will be. Now here you have to stop your too much enthusiasm, otherwise you will perforate. And now I'm coming down. The white one is the cavity created and the pink one was a previous cavity. The biggest problem was whether this cavity will remain the same. Otherwise, what's the use of this surgery? So what you do is at the end of a surgery, you know that triangular cavity you converted into tubule, just decrease the intra-abdominal pressure and you see so many blood vessels opening up. I say Ganga bahti hai. Can you see that? So you know that probably she has a good blood supply. Keep her on a post-operative estrogen progesterone and look at this. Definitely this is more roomy cavity after 6 weeks of estrogens and progesterone. On 3rd, 4th day of a withdrawal bleeding, I like to take them so that I can see, and if needed, I can do once more. So friends, what is important is after climbing a great hill, you find that there are many more hills to climb. You never reach on the top. And I never want to reach, because you reach the top, you have to downfall. I don't want that. I better think of climbing on another hills. That's what your mind should be all. So another 5 minutes of lecture. A mind is like a parachute, doesn't work unless it is open. And that's where I'm going to talk about stem cell, the new field which I entered in 2015. Frankly speaking, I have not entered for infertility. I've entered for another degenerative condition, to regenerate the kidneys because of diabetes, it got collapsed. And then when you have a facility, again, your creative mind starts saying you have a stem cells and they have a potential in regeneration. Last 2 decades, so many people, no more now on animals we talk about, we talk about on a human being, and last 1 decade, the publications on human being. I think India also has to move on, and we started thinking that why not take those stem cells and inject into the ovary and regenerate the ovary? Why not to make the ovary to produce their own egg? Donor egg is so easy option, so easy for us to say. But imagine the patient, imagine yourself, you needed it. Will you go for donor, or you will try your best to take out your own eggs? And that is where this is again, I give a thanks to Dr. Madhuri Patil, who is the editor-chief of Human Reproductive Sciences. She asked me during that period to write a review of literature. And while writing a review, I realized that all people have done study up to the age of 40. Ours was world's first baby at age of 45. To make a world record, especially sitting in India, where research facilities are so less, it's very, very difficult. But I'm happy in lifetime you could achieve something in world record. So what we do is, it is a very simple, from a bone marrow under local anesthesia, around 100 to 150 cc of a bone marrow is aspirated, and then with a specialized technology, automated, in 30 minutes, the centrifugation happens and the stem cells get separated from the RBC and other blood components and from the plasma and the bony spicule, and you have those stem cells to use it for your patient. So if you don't challenge yourself, you will never realize what you can become. So keep on challenging, and we do the stem cells even for ovarian regeneration, but endometrial regeneration. Very many patients don't want surrogacy. Surrogacy is becoming a law in India. It is getting banned for a commercial use. So we need to work on the endometrial cavity so that we can help our needy people. So these are the bone marrow which I'm putting in. This is a second sitting. You can see the fluffy endometrium which has developed, but it was not up to the mark. So in second sitting, we are doing. I do believe these are not yet insurance covered. Insurances have to cover. I know that insurance for a stem cells for a bone marrow transplant has come in. So the time will come when more and more indications will fall into. Today, it is still under experimentation. There is no permission. You need to develop your lab. We have applied for a DCGI permission, and fortunately, 15 days ago, we got our inspection done. And I hope for infertility purpose, I will get the medical or government approval for the stem cells. So friends, intelligence without ambition is a bird without wing. It is not of use. We are medicos, we are doctors, so we know that we are intelligent. Try to be ambitious, try to be master. Don't become follower, you become master. Expect the unexpected. Of course, you have to believe the unbelievable and achieve the unachievable. And here you need a God. Here you need a prayers. Here you need other helping hands and healing hands with you. Don't wish it was easier. Wish you were better. Don't wish for less problem. Wish for more skills. Don't wish for less challenges. Wish for more wisdom. Thank you so much.
Amazing, ma'am. Thank you. Thank you so much, ma'am, for enlightening all of us. Weber, can you make it full screen? Yeah.
Yeah.
Yeah. Thank you. Thank you so much, ma'am, for a lot of more.
Thank you, Ritu. Very exhaustive. Mastering challenges happens over days and days and days and days, and still you keep on mastering them.
Yes, yes, ma'am. But thank you so much. Such a beautiful videos you have shown us. You have motivated lot of us again. Weber, if there are any questions via YouTube or Facebook, please take. Ma'am, you told us about your motivation to become a doctor. Now, what motivated you to become a gynecologist?
You know what? Frankly, after in our time, your third year marks takes to the next post graduation. I was getting general surgery, I was getting gynecologist, I was getting ophthalmologist. In ophthalmology, only once it was there. I was the first. My friend who was second, he is an ophthalm now in Sholapur, very famous ophthalmologist. He always used to say, Sunita, you are not taking it now. I said, I can't work on such a small organ. I could not do rectal examination and a hernia hydrocele examination. That is why I did not enter into general surgery. And that's why I came into gynecology, because I don't wanted to be a physician. My anesthetist head there wanted me to take anesthesia. So for her, I did 6 months in anesthesia. We used to have an option of second house post of your choice, parallel allied branch. I was going to do surgery, but she made me do anesthesia. And I did not like sitting on the head and watching surgeons do. I said, no, I need to be gynecologist myself. And that's how I entered. And 1989, when I was passing, Harry Rich did the first laparoscopic hysterectomy on the world. I was exam going. During our government college, you get 1,000. You all know that. Government college, we resident, we work like a donkeys. We don't get sleep. We work 24/7. We don't remember for 48 hours we have not slept. So by the end of your post-graduation, you have done hundreds of scissors, hysterectomies and all, and you feel what next now? And that's why I never wanted to become a lecturer. Harry Rich did first lap hysterectomy, and I think that is where I moved on to endoscopy.
Okay, great. So, friends, besides such a great accommodation and a great doctor, ma'am is very much emotional also. Ma'am has initiated a Mahamrityunjay Mantra initiative for all of our doctor fraternity. Ma'am, a big salute to you for that also. Your things are motivating us lot and lot. Is there any other questions? Is there any questions, Vaibhav? I think no questions there. He's not writing anything.
Thank you so much.
Yeah.
Thank you for opportunity. Even if I spread spirituality with the people here, I'm more than happy. Believe me, we all need to understand one day we have to leave.
True. Ma'am, before we wind up, I would like to felicitate you with this beautiful shawl. Do it. Thank you, ma'am. Thank you so much. Whenever we meet, ma'am. Yeah.
You are a golden-hearted girl. I have always seen you smiling, moving ahead. You are example to many more. Keep smiling. God will always. I also know every time you say Jai Mata Di, so you are probably the Mata Bhakta. See, all together, yeah, power is power. So we all are somewhere connected, small part. Thank you so much.
Yeah. Thank you so much, ma'am. As there are no questions, so I'm handing over to Sankalp for the concluding marks. Yeah.
Thank you so much, madam. It was a very interactive, knowledgeable session. The doctors who are watching it must have learned so many things out of your presentation, ma'am. It was wonderful, ma'am. And thank you so much for coming on this show, ma'am. We are from Care Life Sciences. We are a company, 6 years old company. We have a infertility as well as obstetrics related practice related products. We have a pregnancy care as well. So looking forward for your valuable support for us also. Thank you so much and good night, ma'am.
Thank you. Good night.
Thank you, Ritu, ma'am.
Bye, Ritu.
Yeah. Bye, ma'am. Thank you. Thank you so much. Yeah.
Thank you.
So before we wind up, stay tuned for the next week. Next week, we are having 2 more stalwarts, Dr. Vineet Mishra, sir, and Dr. Kiran Kohila, madam. So till then, bye-bye. Stay safe, stay healthy.